Thanks, Anna. Hola, buenos días todos. Soy muy contento ser aquí hoy a hablarse sobre mi trabajo en asesoría genética y nuestros proyectos Latin-SEQ Plus. Y ahora en inglés. So thank you everybody for coming today. I'd like to first of all allow or invite my new colleague, Liliana, Dr. Liliana Arias to introduce herself. She's the newest member of this team. So please, Liliana, over to you.
Thank you, Lorraine. Hello, everybody. Hola a todos. Creo que lo voy a decir primero en español, que creo que es un poco más fácil para la audiencia. Pues bienvenidos, mi nombre es Liliana Arias. Yo soy asociada a investigación del proyecto de Lorraine, pues que está basado en la Universidad de Newcastle. Yo soy médico, trabajé un tiempo en genética clínica y después hice mi doctorado en Ciencias de la Salud Poblacional en Edimburgo y voy a estar pues trabajando con Lorraine pues, en este proyecto. Vamos a hacer cosas bien interesantes que ella pues más adelante les va a contar un poco más. Over to you, Lorraine.
Gracias, Lily. Okay, thank you. So the aims of today are first of all to introduce Liliana. Thank you for doing that. Just to talk a little bit about the Latin-SEQ Plus study, give an update of where we are up to with the study today, and share some of the resources that we've developed with our collaborators, with some of you. And then just to talk about my role as a genetic counsellor and how I practice obviously within a UK setting here in Newcastle. I'd like to answer any questions that you may have. And then lastly, there's a poll, an online poll at the end, and I'd be very grateful if you would take some time, just a few minutes to complete that. It will just help us to give a bigger picture of the situation that you're working in and how hopefully we can come together to help each other to deliver whole exome sequencing to your patients. So just a quick recap of the Latin-SEQ Plus study. So obviously you all know about the Latin-SEQ study, which is delivering 1,000 whole exome sequence tests to patients with undiagnosed muscle diseases across 18 countries in Latin America. And it's my understanding genetic counselors are rarely available in Latin America. So there are obviously challenges for you as clinicians to deliver whole exome sequencing without that support. And the Latin-SEQ Plus project is to evaluate that whole experience from your point of view, from the patient's point of view, and also to see if there's any ways that we could help to shape the services going forward in the future to make things more accessible. The grant has been funded by the Medical Research Council and the National Institute for Health and Social Care Research. It's a 3-year project and it started in January 2024, so we're about halfway through now. So what have we done? So sorry, first of all, the research questions and methods. So the broad aims are: how is genetic testing delivered without genetic counselling support across Latin America? And are the benefits of a genetic diagnosis, such as tailored treatment, better supportive care, cascade testing, and prenatal testing options, are they realisable in Latin America in the same ways that they may be realisable in the UK or in Europe or in North America? And the project is a mixed methods project. Some of you have already participated in doing surveys, and also we'd like to develop a survey for patients as well. But that will be developed on the back of some patient interviews and clinician interviews to get a deeper sense of the experiences from patients and clinicians' perspectives. There's also going to be some ethnographic observations from workshops, and I'll tell you a little bit more about that later. And the whole aim is really to see what we can learn from each other about delivering genomic medicine. So what has happened so far? So I've had the absolute privilege and pleasure of visiting these places last year in May and June last year, and I'm so grateful for the very warm welcome and hospitality that I was given when I visited Uruguay, Argentina, and Peru. And as well as meeting over 60 clinicians, I also met with Santiago Ordonez. Some of you may know him. He's the president of the Duchenne Muscular Dystrophy Charity in Argentina. And he very much gave me some excellent background and context about the situation in Argentina. drew me this like very simple but very effective diagram, just letting me know the context about healthcare in this country, about how 50% of the population can't afford any kind of private healthcare. They have public healthcare, which can be quite limited. 35% of the population are middle class, so can afford both, and obviously 15% are upper class and can afford basically access to anything. So he was really helping me to understand the context. He also very kindly distributed surveys to people, patients, and families within his organization. And 16 people responded to that just to understand what genetic diagnoses would mean to those people in those settings. And at the end of this talk, there's a link to an executive summary that I wrote about that, the responses of those patients, which was very interesting and important information to know. In addition to sort of speaking to Santiago, I also met with Flor Berto, who I think some of you also might know, and she was super hospitable and just again agreed to be on my advisory group along with Santiago and also with Marie Dima, who is from Chile, who I think is on this call. Hi, Marie. So just this beginning sort of field work was just to gather together these people to support the project and also to understand the context more. So in Uruguay, I was fortunate enough to be hosted by Maria Jose and Emilio Salazar, and together we did some workshops with around 60 clinicians in Uruguay, where we shared some genetic counselling resources and rehearsed attitudes to unlooked for findings. And that was a very informative discussions that we had. And also some of you have done some online surveys, again, about understanding the context in each of your situations. And obviously there isn't any one size fits all across all of these different centres and different countries. So it's really important to understand what context you're working in. So the first question from the surveys and from my experience of talking to people was, so do you have genetic counsellors in your service? And as you can see, it's a mixed response here. So some people don't. And some people just across different centres either have genetic counsellors or not. So again, it just shows the challenges that people have in trying to broker genetic testing without that kind of resource. So in the survey that is at the end of the presentation, there'll be some questions about that, and I would really appreciate it if you could respond to that, again, just to build up this picture of where these resources are available and where best we can support with this project. So from the workshops, the observations that we made from that was that although diagnostic testing is funded by the Latin-SEQ research study by the pharma companies, there was no funding for ongoing cascade testing. So if a diagnosis was made in the family, then people couldn't afford necessarily to roll out that testing across family members. The interpretation of variants was concerning, and also what to say to patients when no diagnosis is made and there was no end to their diagnostic odyssey. That was concerning for clinicians, and also what to do about unlooked for findings. So some questions from Latin-SEQ from the project that have come via Anna and Chamo, via yourselves, were how to explain findings to patients, what to say about variants of uncertain significance, what to say about the unexpected findings, how to give results, and what about testing in children. So I'm hoping to try and give you some examples of how I would address those questions within my practice. It might not be appropriate or the same for you, but I just can only speak from my experience. So I just wanted to talk a little bit about my role as a clinical genetic counsellor and hopefully try to focus on some of those questions while I'm going through this description of my role. So my role as a genetic counsellor, firstly, I get referred a patient who is concerned about their family history of a disease. So in my work, I mostly work with patients who are concerned about a family history of cancer or a family history of renal disease. But the same principles apply across all diseases. So we are referred the patient. The first thing we do is draw the family tree and map the disease of concern across the family tree. So taking a detailed family history from the patient, at this point there is no genetic diagnosis made. So we firstly try to work out who is the best person in the family to offer a genetic test if we do think that this is a disease of concern that could have a genetic link. So if we take this as an example of a family history of breast cancer, the most appropriate person to offer testing in this situation would be this person here. And that would be because in this family, this particular person was the youngest person to have been affected by that disease. And in the UK, we have very strict guidelines. We have the UK Genetic Test Directory, and that gives us guidance on who is allowed to have a genetic test and who isn't. Obviously, it is all funded by the NHS, so it is free to patients, but not everybody can have access to all tests. So with the broad rule of thumb in cancer genetics is if we feel that we have a 10% chance of finding a pathogenic variant in a family with a cancer diagnosis, then we would offer testing. So I would counsel this family about the likelihood of finding a pathogenic variant that would explain this family history. So I would say to them, 90% of the time we may not find anything, but in 10% of cases we might. And what would it mean if we got a genetic diagnosis? So if we got a genetic diagnosis, it would then mean that all of these people would be able to access a genetic test to see if they have a higher chance of developing cancer. And this process is called cascade testing. So that's when we've made the genetic diagnosis and then we cascade it throughout the family to anybody who would want to consider having a genetic test. So the object of the exercise isn't that everybody has a genetic test, but that everybody is offered it and has the information to make that decision for themselves. So in terms of giving the result, I always give my results via letter, or I broker with the patient an agreement as to how they want me to give the result, and it's usually either by telephone or by letter. If it's by telephone, obviously it's a very difficult thing to do if you're just going to phone somebody out of the blue. They could be in the supermarket. It might not be the ideal situation to give somebody a genetic test result. So usually I would give it via letter. And if somebody has been found to have a genetic variant, then I would always offer them a follow-up appointment. So most of my genetic testing in the cancer landscape is done through small panels. But in my work in renal genetics, we use a lot of whole exome sequencing. So this is how I would explain the whole exome sequencing to patients, or this kind of genomic approach to genetic testing rather than the small panel genetic testing. So I say to patients, we have about 20,000 genes and they come in pairs. We get one of the pair from our mother and one from our father. Genes are recipes for making proteins in our bodies, and we need proteins in the right amounts and in the right places for our body to be healthy. Whole exome sequencing looks at all of the recipes for proteins, and that's critically not just the ones that we know that can cause your type of condition, whatever condition we're looking at, but we can find things that we're not particularly looking for, but they are reportable. And whole exome sequencing as if we are looking at all of the pages in the recipe book and not just the recipe pages. So I would, again, pre-test, I would explain to patients that there are 5 possible results. So the first possible result is that we get a pathogenic variant. This is a spelling change in the recipe that explains that person's condition or disease. And as I said, in my work in cancer, it's about a 10% chance of getting that. In my renal work in certain genetic conditions, it's much higher. It's about 80% for diagnosing polycystic kidney disease. And I understand in Latin-SEQ that it's about 70% the chances of finding a disease-causing gene change. So if there's no variant found, then I would say to patients, on this occasion, we haven't found a genetic cause for the condition in your family. It doesn't mean to say that it isn't a genetic condition. It just means to say that at this point in time, we are unable to identify that. And depending on what the family history is and which condition it is, we might still want to arrange screening for people in that family, even though there isn't a genetic cause, because the family history is so compelling and we still think that there is something going on, but we haven't been able to pinpoint it and we aren't able to then offer cascade testing for the family. But we would then go across all of the family tree again and identify which patients in the family or which family members screening would still be advisable for and what that screening would be, and we can give that advice to people. Then if there's a variant of uncertain significance found, obviously we know that this means that we haven't found a spelling change that explains the disease. We need more research to understand this. This can obviously be a very frustrating position for families to be in, because we can't then cascade that information throughout the family. We can't offer genetic testing to other people, and we have to treat them clinically as if we haven't found a genetic cause. And then if we get an unexpected finding, so if we're, for example, looking at renal disease and then we find a gene causing cancer, then we know that at the moment the ACMG reports that there are 84 such actionable findings. And in the UK, we have to tell patients that what those conditions are, and then give them the information for them to be able to act on that. The fifth possible result is that maybe people aren't related to each other in the way that families believe they are related to each other. So my understanding is that in Latin-SEQ that they would not report that. So again, in the survey, which is at the end of the presentation, I'm really interested to know, what would you report? Obviously, people would report a pathogenic variant and report that no variant is found. But I would be really interested to hear your views on whether or not you would report variants of uncertain significance, and whether you would report unexpected findings. So again, going back to my patients, whilst I'm giving them all of the information about the possible results, I would consent them to the test. After going through all of this, I would then manage their expectations about when the result would be delivered. And again, that is a variable timescale depending on what gene it is that we're talking about. If it's a cascade test, so in other words, we know the genetic cause in the family, and this is somebody who just wants to know if they've got that susceptibility to that disease, the result might take about 4 to 6 weeks. If it's trying to find a diagnosis in a family for cancer, it can take up to 3 months. If it's whole exome sequencing for a condition, it can take up to 2 years. So it's a very variable timescale, and this may vary between centres as well in the UK. So this is just a resource that was developed with collaborators last year. I use this in my practice as well, obviously a UK version of it. But if I'm talking about genes being recipes for making proteins, this is how I would explain all of the different scenarios. So if a spelling mistake says, and instead of saying a quarter of a teaspoon of milk, for if you're imagining a gene as a recipe to make an omelette or a tortilla, and if the spelling mistake is a fifth of a teaspoon of milk instead of a quarter of a teaspoon of milk, the recipe would still produce a tortilla. That wouldn't change the outcome, and our bodies would still recognize that as a tortilla. And this is what's called a benign variant, or a part of normal variation in the population. So I would explain to patients that is one end of the spectrum. On the other hand, if the spelling mistake is the V for huevos is replaced with an S for huesos, then obviously this would not produce a tortilla. This would get a very different outcome. Our bodies wouldn't recognize this as that protein, and that is called a pathogenic variant or a disease-causing variant. And then I would explain that a variant of uncertain significance is somewhere between those two extremes. So at one extreme you have the disease-causing variant, and at the other extreme you have the benign variant, and it's somewhere in the middle is this variant of uncertain significance. And importantly, that variant can change. So as further research is done, all of our variants of uncertain significance are reported to national databases where the further research is undertaken to try and define whether these are pathogenic or whether they are benign. And I've had situations where variants have been reclassified in families in both directions. For example, a variant of uncertain significance has been classified as pathogenic. People have acted on that and had risk-reducing surgery and had quite invasive procedures undertaken. Then several years later, that same variant has been reclassified as benign, and we've had to go back to those families and say that this has been reclassified, and that those quite severe things that they've had undertaken to reduce risks have been in vain. So it's a very uncertain situation and very worrying situation when that happens. So I try to tell people up front that this can change in either direction. So if we find a genetic cause of disease, so I would deliver the news to people. As I said, I would usually write to people. So that gives them some time to process the news. Often it can come as a shock to people, even though you've counseled them pre-test and people are pretty sure that they want to have the test. It can still be a shock to people when they find out. In the case of whole exome sequencing, is it expected? Is the plan of care or intervention, does it change because of this diagnosis? Are any other members in the family presenting with the same phenotype? And are we sure that this genetic cause is the one that's explaining the phenotype in the family? And what does it mean for other family members? So if you imagine back to that family tree drawing, all of those individuals who might be at risk, how can we go about contacting them and inviting them to be tested if it's relevant? And how is this information communicated to family members? So within our practice, the way we do it is through the person who comes to see us. So whichever patient has seen us first, we would give them reply slips to pass out to their family members, and then they can return the reply slips requesting an appointment if they would like that. It can be difficult in families to do that if families have fallen out or have no contact with each other or have moved away or have living abroad or intervening relatives have died. There's lots of difficulties about contacting families, but we try our best to do what we can through existing family members who we're in contact with. Obviously, we clarify what the inheritance pattern is, and as I said, offer cascade and predictive testing. So what about cascade testing in a person who is fit and well, who doesn't have a disease? What can be done for them? Again, it's very disease specific, but we would have a conversation with them about what screening is available to them now. So there may be different age limitations depending on the disease. For example, in a breast cancer family history, a woman would only get breast screening in the UK if she had a gene change causing breast cancer from the age of 30, or at the youngest at the age of 25 if she had an exceptionally high risk. So what age is the person now and what age would they first get screening is a conversation that we would have with them. And then also what screening is available to the patient in the future. So if it's not available to them now, when would it be available and what would that be? Is risk reducing surgery a possibility? And if it is, would they want that? No risk reducing surgery is mandated, purely a personal choice. Obviously, it's very invasive and can be like a life-changing event. So somebody has to be pretty certain that they want to go through that, and it's purely their choice. And are there any early or pre-symptomatic treatments for whatever that disease is? And also, it's very important to highlight to the patients what can be done without having a test so that they've got a fully informed picture of if they have the test, they can do this. But if they don't have the test, they can also do this. So many people can get access to screening by virtue of being at 50-50 risk of having the gene change. So they don't have to actually have the gene change to get some screening if they prefer not to know. So another part of the conversation about testing an asymptomatic person is the timing right. So in the UK context, depending on how old the person is sitting in front of me, having a genetic test where that might predict that you're going to become ill at some point in your life can sometimes affect your ability to get certain types of life insurance. It would stop people from getting life insurance that would cover their mortgage payments if they became sick. If people are planning to emigrate and live abroad, sometimes having a genetic susceptibility to a disease means that they would fail a medical for emigration. Are they planning to have a family? Would they want to access pre-implantation genetic testing or prenatal diagnosis? Are they about to join the armed forces? Do they want to join the armed forces? Again, they might not pass a medical to join the armed forces if they had a susceptibility to certain types of disease. And also certain careers may be out of bounds for people with certain kidney diseases, for example, being a pilot or, again, being in the armed forces and that kind of thing. And then also, what does it mean do they have children and what does it mean for their children? So is the timing right for them now? So sometimes people might come to me and they might have this conversation and decide actually it's not the right time now, that they might go ahead and have screening for themselves, but then come back at a later stage. They might want to buy the house first. They may want to get settled on their career track first, and then they'd come back. And basically, it's not a one-stop opportunity to be tested. It's an open door access policy. People can take as long as they want to make a decision and come back to us maybe months or even years later. So again, a question for the survey at the end of this presentation would be, is pre-implantation genetic testing available for patients in your country and in your setting, and is prenatal diagnosis available too? And I'd be really interested to hear about that. And one of the questions that was asked via the Latin-SEQ study is, what about testing a child? Testing in children in the UK setting is we would only test a child if the child can be affected by that condition. So we'd need to ask a certain set of questions about the disease to see whether genetic testing would be accessible to children. So at what age would the youngest person with this condition present? How variable is the penetrance? What is the range of the severity of the condition? And is it a predictable severity? Also, are there any monitoring or screening or treatment interventions for children with the condition? Are there any guidelines for best practice and care? For example, in autosomal dominant polycystic kidney disease, there's a UK guidance that says children can get screened from the age of 5. So that has opened the door on permitting cascade testing to children and families with adult polycystic kidney disease. And if the child isn't tested now, but say if they're at 50-50 risk of having the condition, would they still be able to access these interventions? And in the example of polycystic kidney disease, yes, they would. They would still have access to that screening, even though they're only at 50-50 risk. But part of the decision-making process is trying to not close the door on opportunities for children. And if they can make that decision for themselves when they're an adult and they can consent to the test themselves, we feel that is a better situation for them to be in, as long as they are not having any detriments to their health in the meantime by delaying that testing. So in decision making for parents and children, so if they decide not to test, then it would be important to offer another opportunity to discuss genetic testing when that child is in their teenage years, as reproductive options may be available and potential consequences for their future children should be explained, just so that they understand what the options are. Obviously, there's no obligation to take up any of those options, but just so that they are informed. And also, if they decide not to test, it's really important then to refer them for any screening that they are eligible for now and make sure they're not lost to follow up. And then if they decide to be tested, obviously we need to arrange with the family on how the result will be communicated and what the likely timescale is, and to try to give the result via letter and then follow them up in a clinic appointment. Obviously, across all of the genetic counselling process, emotional and psychological care is really important. We know in families that although there's no reason why anybody should feel guilty or should blame people, that families do experience these emotions. And quite often having a genetic test can change family dynamics because not everybody wants to know this information. And if a parent has found out this information, but their adult child doesn't want to know, that can cause family disturbances. Some people have very strong views about whether they want to be tested or not. And whilst as genetic counsellors, we are not coercive in the slightest about having a genetic test, we know that in families, people can be very coercive with each other, and this can cause upset. Also, people can have experience increased health anxiety, especially around getting a genetic diagnosis of a susceptibility to cancer. People might feel every ache and pain. Is this something happening? I'm really worried about my health, they would say. And the ways that we manage all of these things are, first of all, to try and frame the information in as positive a light as possible. I say to patients, you've had this gene change all of your life. We now know about it so that we can do something about it. I try to normalize the fact that they've got a gene change. I emphasize that we all have spelling changes in our genes. It's just that the majority of us don't have the opportunity to find out what they are. And that now we know that this information, we can hopefully do something about it and improve your care. It's nobody's fault that we have this. And also, after a period of adjustment, people usually manage to put this information into their lives, into the back of their minds, to get on with their lives and use it in a positive way. But some people need more emotional support and maybe some psychological counselling to come to terms with this. So in summary, a genetic counsellor's job is a balancing act, really, to present options to patients and to try and balance the benefits of genetic testing with potential harms so that a patient can make a decision that is right for them at this particular moment in their lives. And so obviously the benefits are potentially better care, screening, risk management, getting information for other family members and access to prenatal options. And potential harms are possible psychological harms, emotional harms, family relationships that might change for the worse, perhaps losing a sense of an open future, and may impact careers and financial arrangements. So next steps in terms of our Latin-SEQ Plus studies, I'd be very grateful if you could take a few moments to complete the survey, and I will do my utmost with Liliana to respond to your requests for any resources and help that we can give you. We're very keen to do that. Liliana would like to progress the next stage of interviewing patients about their experiences to find out how having a genetic diagnosis has impacted their lives, talking about quality of life as well. So if you would be happy to work with Liliana directly, please email her on her current email address. And also the information that we got from the workshops about pharma-funded research, then not allowing funding for cascade testing. I'm really interested to know if anybody would like to work with us to develop a paper around that, to try and do an opinion piece about this, to highlight this as a kind of a missing piece of important work that needs to be considered when pharma are funding studies. So if anybody is happy to collaborate on that, would be fantastic. I would like to do some interviews with clinicians if anybody's happy to speak to me in English, or we can do it in Spanish and I can translate it or have a translator with me. That would be great, again, just to have more in-depth knowledge about your experience of delivering whole exome sequencing. And then lastly, I am going to be visiting South America in November this year, and I would really love an opportunity to work with you and find out more about your service. So again, if you're happy to do either the kind of work that we did in Uruguay, or if you want us to develop something else, please email me and I'm happy to work alongside with you to develop that. And I think that is it. Yeah, here are some resources. Again, it's the link to the survey. Also, we developed a 1-minute animation in Spanish that explains whole exome sequencing. Please share that with your patients if it's helpful. Testing children, there are more notes about that you can find in this link here. It's in Spanish. I can put in an English version as well for non-Spanish speakers. And also the executive summary that I talked about from the patient questionnaire, from the patients from the Duchenne Muscular Dystrophy charity in Argentina. There's this link here to that. I think I'll stop there.
Can I ask my questions?
Yes, please.
So one of the questions was that I wasn't aware that some people were not allowed to be tested.
Yeah.
What are the rules for that, and is that disease specific?
It's disease specific, so that the genetic test directory has very stringent rules about who can be tested and who can't. Our laboratories actually police that now.
Okay.
So they will bounce back samples if they don't meet the criteria.
And what are those criteria?
It's disease specific. Yeah, they're very actually difficult to interpret. Yeah, but it's different too for all of them.
So with cascade testing to reach the family members, is that through the patient or?
So it's usually always through the patient, but it can be difficult if people don't talk to each other. But it can be an iterative process. So although that person might not speak to other family members, if we get to see their sibling, that sibling might have contact with other family members that they don't. And so we snowball the process. So the only time that we would do it through a GP is if somebody died and there's no other link to the family, then we would write back to the referrer and say, if you have any contact with family members, please share this information, or we can get their GP address, their GP contact details, and write to the GP and say this information is available for family members if they want to access it.
Okay, and do you cascade variants of unknown significance as well?
No. We don't offer cascade testing. The only way we would test other family members for variants of uncertain significance is if other people in the family have symptoms of the condition or features of the condition. So it's a way of garnering evidence to say, is this a pathogenic mutation? So if you've got other family members, what's called segregation analysis. So you look to see if the people who have got symptoms have the same variant, or if they don't have the variant, and that can be informative. But we don't do it in pre-symptomatic people.
Yeah, but I always find that is, at least from our point of view, that it goes against. So when you have a variant of unknown significance, if you are able to test not only the affected individuals, but also the non-affected, unfortunately, that if you can segregate the variant both
ways, yeah,
ways, that actually you might be able to downgrade or even upgrade.
Yeah.
It's a bit frustrating from our side, I believe.
Yeah. Again, that is, there's been rules introduced about that as part of the UK test directory. So again, there's like too many conditions to name, and obviously I don't know all of the conditions that would do it, but sometimes cascade testing isn't done. You can't even do it phenotypically, depending on the rarity of the condition, or if it's a recessive condition, or so there's lots of rules around it that there weren't 10 years ago, for example.
And the last one that I think is related to the survey is that at some point you asked our colleagues in Latin-SEQ whether they would report a variant to the patient. So in cases, I think at least that's what I understood, that you were asking if a variant of unknown significance would be reported, or an incidental finding would be reported.
Yes, that's right, yeah.
And I was just wanting to clarify that. Is that reporting, it wasn't a question to us, it was a question to our colleagues whether they would report it to the patient?
Yes, that's right. It was a question to the clinicians. Would they tell the patients about that finding?
That I really don't know how that's been done so far. So that's the thing for me as well to know.
Yeah.
If we with positive findings.
Good day. How are you?
Good, thanks. How are you?
Thank you for the great presentation, Lorraine.
Thank you.
I would like to participate in telling you how in Guatemala, when you get an exam result and you get a variant, that's an incidental thing. I think that when you have a pathogenic variant that goes with the phenotypic version of what you find in a patient, you can say it. If you have a pathogenic variant that's not related with the patient's symptoms, where you have to be sure if the family can support having another illness in what you can manage emotionally, if there's like very little chance of in a moment in 10 years or 20 years to have the illness. So you have to evaluate. That's what I do personally. If you have a VUS, then if you didn't find the genetic variant, you can report it if it goes with the phenotypic explanation that you were searching. It's not the diagnosis. You have to be clear with the patient and the family. And when the incidental findings, in my experience, right now I have a 10-year-old girl. I knew I will find a channelopathy, and I didn't find it. I had a myocardiopathy and also amyloidosis, and that the amyloidosis finding, you can relate it with cardiomyopathy, but that wasn't what I was searching. So it's an incidental finding also. I'm like trying to find a way to tell the family, because they have various deaths in the family, but it wasn't what I was searching. And also amyloidosis, you find it not in an infancy or that young. I had a nurse, a genetic consult nurse who trained me. I'm a doctor. To give these findings to the patients and families. I think that's the procedure that I do with my patients and families.
Excellent. Yeah. Thank you. Thanks for sharing that, Maria.
You're welcome, Lorraine. Thank you.
Actually, I think Maria's experience is a really nice example of the challenges that we can face when giving genetic results or when going through risk assessment and this kind of thing. So, Maria, that's the reason why we want to interview people. We would like to know more about your experiences and your views about these challenges. and how you negotiate different kind of routes. So you are more than welcome to participate in the interviewing process.
Thank you, Liliana. I already answered the survey, so I think you have it. It's in Spanish, but you can tell me if you need something or Lorraine needs something. I'm pretty open to know what's your opinion and maybe to have some interaction. Let me know.
Super.
Thank you.
Absolutely. That's great. Thank you.
Perfect. Thank you. Thanks, Liliana, as well. Thank you.
Thank to you.
Lorraine, anything else from your side?
Really, just to say thank you so much to everybody who has taken the time to answer the survey or has answered a survey in the past. Please do reach out if you feel that you could benefit from having some workshops, or I'll be traveling to Chile to work with a genetic cancer in Chile, but I'm very happy to extend my visit to other places and to work with people more on a one-to-one basis. It was super beneficial for me to do that last year, and I'm really looking forward to do that again. But thank you for your continued support and collaboration.
John, thank you so much, Lorraine, for your talk. Really enjoyed that.